Now the last talk is by Dr. Mahesh. He will be talking on common mistakes in HCQ screening.
Thank you, everyone. So this is a very important topic because every day I see a lot of references where the ophthalmologist has given a letter to rheumatologist. There is some scotoma in the field and OCT shows thinning. So stop the medicine. This is what all our members, our ophthalmologists are giving report. And this is actually wrong. I want to show some slides. What are the mistakes that we do when we screen for HCQ. The recommendations of HCQ screening has been modified based on the 2016 AO guidelines. And there are actually HCQ is a fantastic drug given and it's something like a drug of choice for SLE and lot of other diseases, steroid sparing drug. So that is the beauty of this drug. It finally affects, it causes changes in the retinal photoreceptors. Not, it primarily affects the retinal photoreceptors, mainly cones because of the central accumulation of cones. And once the cones degenerates, the other outer nuclear layer also degenerates, then RP goes. Once RP goes, there is no recovery. So this is the pathology, how HCQ affects this thing. So daily dose, this thing you should remember, daily dose greater than 400 milligram, 200 milligram BD for around 5 years, or a cumulative dose of more than 1000 gram for more than around 5 years can theoretically cause accumulation of the drug. But this is modifiable because some patients have liver disease, renal disease, clearance will be different. So underlying retinal disease may be there. So these are all things that can affect. So, but usually it's a very safe drug. That is what I want. So all of us know what is the finding? Bullseye maculopathy. Bullseye maculopathy is the last stage of the disease. At that stage, there is no point in diagnosing. You can't do anything. It will not recover and finally it will further deteriorate. So that is not the importance. We have to find the thing at the early stage and then stop the drug as and when necessary. So what are the earliest findings in disruption in HCQ? The field shows some paracentral scotoma. This is 2005-7 like that. Autofluorescence is very useful. Some hyperautofluorescence is there. And here, correspondingly, there is a disruption of the EZ, ellipsoid line, which is the photoreceptor the layer, that EZ loss is there. And sometimes RP also will degenerate. So this is the typical finding. And corresponding to that area, there is a multifocal ERG, waves are reduced. So this everything should be correlatable. Then only you can say there is definite HCQ change. So statistical risk is very less, in fact. Different studies are there. Some studies show 7.5%. The risk of toxicity in less than 5 years is only 1%. Up to 10 years, it is 2% only. That means if a patient is taking HCQ for 10 years, the chance of getting a problem is only 2%. 98% will not get a problem. There are two things based on the ideal weight and actual real weight and ideal weight. Initially, they used to calculate dosage based on ideal weight. Now it is a real weight. That is a real weight that is calculated for giving the drug. That means a thin, frail person will get less dose actually. So baseline screening, a person is referred to you. You should have a baseline screening of fundus examination, visual fields, and OCT. This is a baseline test, even if the patient has comes at 6 months or 1 year. This can be used for further future tests. Then the annual screening actually begins after 5 years of use. Or if there are some risk factors like some other liver disease or something, obesity or something like that, you can call little earlier. Okay, so recommended screening tests are automated visual fields, usually 30-2. Why I will tell you. Then SD-OCT, not time domain OCT. The 50% of OCT that I see in my practice is referred by some, where the doctor has done a time domain OCT and found a thinning and then stopped the drug. It is very dangerous to stop the drug unnecessarily. And multifocal ERG is only in some cases we do. Autofluorescence we have, so we do that. Microperimetry, all these things are not done routinely. Time domain OCT has absolutely no value in HCQ screening. I am again telling. and also color vision, all these things have no value. So once you detect it early, you can stop it so that it doesn't progress. But like in ethambutol, once it is beyond one level, you can't. So this is already that you can see that there is a something like a bullseye here. Vision is already gone, and this is multifocal, multicolor imaging. You can see that already there is something like a bullseye, and infrared and fundus autofluorescence. The typical bullseye is there. Wherever that dark area is there, there is complete loss of RP and ellipsoid. Photoreceptors and RP are gone. The hyper autofluorescence area has some cells remaining. So this is the how to correlate autofluorescence and the fundus picture and OCT. Now this is bullseye maculopathy. You don't need a big head for diagnosing bullseye maculopathy, and there is no use of bullseye diagnosing at this stage. Now coming to some other cases. So here this is a case where vision is quite good, and here from this area to this area there is loss of ellipsoid line. So that is the significance. And in the central area, it is still preserved. That is called flying saucer sign, foveal resistant, because fovea is still, that ellipsoid line is present. Ideally, this is what I do. Across the macula, scan level by level, section by section, and see whether there is any ellipsoid loss in any of these sections. So you can see actually the ellipsoid loss is mainly in the at the arcade. It is little away from the area. So this is typically seen in Indian population, Asian population, unlike a Caucasian where you get everything near. So with one section of the OCT, never comment. You have to sit with the machine, go from here to here and take all sections and then see if there is any ellipsoid loss. So then only you say there is some problem. Okay, now in this case there was a big scotoma, like a ring scotoma sort of thing corresponding to that loss of RP. So this is the other eye. So these are the goal of screening is not to stop valuable drugs at first borderline abnormality. Don't ask the rheumatologist to stop the drug. You give your comment. Whether to stop it or not is decided by the rheumatologist. So recognize definitive signs of toxicity. So this is another case where referred for HCQ screening for 2 years, 6x6 N6. Okay, field was reasonably good. And one doctor from elsewhere has advised thinning of fovea and stop HCQ. The letter is given, one of our friends only. This should not be done. Where is the thinning? They saw this green and it is red in the center. So it is like managing a field based on grayscale. Never do that. See this, there is thinning, then stop it. So it should not be done. In fact, I did across the macula, there is a scan there. I did all the layers. There is absolutely no change. So this was unnecessarily, the patient has stopped HCQ and had a remission of all problems. She was asking me whether I can continue that. So this is what is happening by our ophthalmologist screening across Kerala. So please make sure that you sit with the machine, go through all the sections, then only give a comment to stop the HCQ. So the mistakes are, one, don't ask to stop HCQ based on central macular thickness. Now don't tell us there is thinning, you stop HCQ. That is absolutely rubbish. I am talking with little, because I see this daily. So don't ask to stop HCQ based on few scotoma in the paracentral, because unfortunately field is a good test, but it is difficult to, patient finds it very difficult to do. So with your OCT, you sit with the patient across the section, you just see, you will be able to find out. Check history. If it is only 6 months, patient is unlikely to have HCQ toxicity. So use a little common sense also. That is all. So in the reply letter, you write, no HCQ related changes in retina, suspicious changes in OCT, autofluorescence or field, need closer follow-up and repeat test. Definite HCQ changes like the first one may be stopped. Here you can definitely say there is no point in stopping, but you can say. Then the fourth one is where there are other changes in retina like CSCR or AMD or drusen or something. So the early HCQ toxicity may not be picked up. Okay, this you can comment clearly. Because of the other diseases or CSR or AMD, HCQ toxicity cannot be picked up. Put the ball in rheumatologist's court. Let them decide what they want. Okay, so these are the reply that you have to give. HCQ is a very safe drug. Do not ask to stop the drug based on some vague findings. You are doing harm to the patient. Thank you very much.
Thank you, Dr. Mahesh, for that informative